First patient is a 47-year-old male, fell from a ladder onto his left hip with this left acetabulum fracture. It was non-displaced. A CT scan was obtained. Due to the congruity, he was managed non-operatively and made toe touch weight bearing on that extremity and was discharged on DVT prophylaxis. Next patient is a 75-year-old female who opened the door into her face and fell backwards. She has a right pubic rami fracture. She was neurovascularly intact, and of note, she did have an old LC1 pelvis on the left, and she was made weight bearing is tolerated. Next patient is a 35-year-old female who works at Costco when a forklift pinched her foot between a shelf. She has this left great toe P1 fracture as well as a fourth P2 fracture. She was put into a hard sole shoe, and she will follow up in the office this week. Next patient is a 33-year-old male. We were consulted for a wound check on him for the ED. He dropped a pipe on his hand 3 days prior and suffered index finger and ring finger distal lacerations that were about 1 centimeter and sutured by the ED and washed out. And then 3 days later, they called us for this non-displaced right small finger P2 fracture. He was buddy taped for comfort. Next patient is an 18-year-old male. The story was that he was at high school wood shop class when his hand got put into some sort of chainsaw. He suffered multiple finger lacerations superficially, and then a partial amp on the small finger. Of note, the radial digital neurovascular bundle was cut on the small finger, and he also had no extension at the DIP joint. He was washed out and sutured, and then the patient actually ended up leaving and then coming back for a psych consultation because there was concern that this was non-accidental, and he is currently being managed in the hospital.
Good morning. First patient's a 75-year-old female, status post-fall. They left bimal ankle fracture dislocation. Was initially closed reduced, placed in short AO splint, and taken for ORIF. Next patient's a 48-year-old male, status post-MVC. They left distal radius fracture and left clavicle fracture. Clavicle was treated with a sling. Distal radius was closed reduced and placed in sugar tongue splint. Next is a 14.
Jason, what else did he have besides a distal radius fracture?
He also had like the ulnar style. The end of the ulna was disrupted as well.
And where in the ulna was the fracture?
Right there.
So it wasn't just an ulnar styloid, right?
Yeah.
There you go. So that may instruct you that you wish to consider operative intervention here just because of the severity of the injury.
Correct.
What about the clavicle makes you concerned for something else? Is this typically what a clavicle fracture will look like when you get an x-ray?
I think there's a little bit more space between the fragments than usually.
So it's distracted and it's a high energy mechanism. What else would you want to look for or evaluate for?
So with like a high energy clavicle fracture, you'd be worried about like rib fractures, maybe like scapula, brachial plexus.
Okay, was he neurovascularly intact?
He was.
And you were able to get an exam with the distal, well, it's actually a both bones fracture.
Yes,
You were-
I was able to get an exam. He was neurovascularly intact. Next is a 14-year-old male, status post-fall with the left open both bone forearm fracture. There's a 1 millimeter poke hole on the volar side. He was closed reduced and placed in sugar tongue splint. Also would be a watcher for a close follow-up. He was sent out.
And the antibiotics given were what?
He got Ansef in the ED, and then we'll be given Keflex outpatient. 1 week.
Is that typical with the open ones in pediatrics?
So with type 1 open pediatric fractures, I believe there's some literature to say that the outcomes in terms of infections and complications are similar with non-operative management and IV antibiotics in the ED with operative washout.
It takes a long time to get used to this idea, but that is what people are doing now. But it has to be a pinhole opening. It can't be a high energy mechanism, and you really have to consider what the injury is underneath and whether you can maintain a stable reduction. If you're going to have a hard time maintaining the reduction and you're going to go to the OR anyway, maybe you're going to think you're going to need to, then you probably still should wash it out. But that one is one I would consider doing what you did here.
All right. Next is a 33-year-old male with cerebral palsy. He stepped on an object and rotated his foot awkwardly with left third through fifth metatarsal neck fractures. Minimally displaced. He was placed in a hard sole shoe.
Good morning, everyone. First, we have a 10-year-old male, status post cartwheel with his left both bone forearm fracture. He's closed reduced in the ED, placed into a sugar tongue splint. Next, we have a 10-year-old female, status post ground level fall. She's sustained a right pathologic subtropic femur fracture. After work up here in the emergency, she's provisionally splinted, worked up here in the hospital MRI, saw that she had lesions consistent with fibrous dysplasia, polyostotic fibrous dysplasia. So she was transferred up to Newark for definitive care.
So what really happened with her is our own PEDS team contacted Kathleen Beebe themselves and kind of went around us. So they were kind of already in the process of being transferred up there before the MRI was even obtained to see what kind of lesion it was. Looks like it's probably just polyostotic fibrous dysplasia. And then what's interesting is that she ended up getting transferred up there and then apparently was very unhappy with the floor care at Newark. And then the following morning demanded to be transferred to CHOP. So this patient got transferred 4 times, I think, 3 or 4 times, because I think they were transferred to our institution before receiving care. So I think the take home point with this one, so Kathleen Beebe does come to our institution. She has privileges here. So I think the take home here, I've had a conversation with her regarding this patient too, is our pathology department. So she still doesn't feel comfortable with our pathology department and reading frozen sections and felt more comfortable just doing a frozen at her home institution and then treating this. So we're in the process of working with our pathology department to be able to do a true musculoskeletal frozen section that's trustworthy. And then these cases can be done together with our PEDS ortho department here and Kathleen Beebe.
Joe Moore, how would you manage the fracture? Let's say the patient did stay in our institution.
Sure. You could do pediatrics in kids with femur fractures, her age, her weight. You could consider internal fixation, flexible nailing. You could do plating as well. I talked about this with Dr. Adolphson, and the sort of after going on about it, we spoke about it for a little while, and ultimately came up with the idea that probably in this case that flexible nailing was the right choice for her.
Yeah, go back to your images, go back to your x-rays. So is it just one lesion?
No. It's all the way. I mean, it's probably best seen on the MRI. It's all the way through the.
So it's through one of the lesions.
Yep.
And there's a pretty concerning lesion. I don't know if it showed through there very well, but in kind of the intertroch, subtroch area, just above it too. Yeah. And then there's a distal lesion as well. So I think you definitely would err on something intramedullary here. I think flexi-nails is a decent option. I think it's more of this is an isthmic fracture, not really a subtroch fracture. So I kind of call it a proximal shaft fracture. So I think it's okay to consider flexi-nails. I probably would supplement it with a one-legged spica for a few weeks, just for comfort. And then on first added, stability, and then take the spike off in the office after 3 weeks. I think this is also one where you could consider doing a rigid lateral troch nail if she were big enough for the 7 millimeter orthopediatrics lateral troch nail. That might be actually a good indication in this case, just to span all of those lesions.
And does anything have to be done at the lesion itself, or can all this be done, through incisions on the front and the back?
Yeah, I don't know that anything needs to be done at the lesion. If you're suggesting like a curettage and that kind of stuff, one paper I read on this showed that most of curettaging and bone grafting ends up getting resorbed, and it gets replaced with the same kind of weak woven immature bone. So it's not, especially in polyostotic cases.
Yeah, I think it's a good question, Brian. I think Dr. Beebe wanted to have some type of path just to prove the diagnosis before putting something in there. So I'm not sure she's ruling that out of going back at some point and bone grafting that, because I know when it is a single lesion through a fibrous dysplasia, some of us will consider curettaging that and grafting it if it's in a femur too. Maybe not right away though.
Thanks, guys. Next is a 13-year-old male. He stubbed his toe playing soccer in his right great toe P2 fracture. He's made weight bearing is tolerated in the hard sole shoe. Next is a 90-year-old male found down. Found to have this right posterior ilium fracture. It didn't appear to affect the rest of the pelvic ring. So he was made weight bearing is tolerated. Next is a 61-year-old female. Stats was ground level fall. He has this right patella fracture. She had this right patella fracture. She was able to straight leg raise. She was made weight bearing and extension with a bulky knee immobilizer. She'll follow up in the office. Next is a 71-year-old female found down with this left tibia shaft fracture. Note, this patient has dementia, diabetes, ESRD. She has a 90-degree flexion contracture. She's non-ambulatory. She's a seizure with residual left-sided weakness and the subsequent contractures. And she also has a seizure subsequent to the CVA. So the decision was made to pursue non-operative management for this patient. She was placed provisionally in a short leg splint because of the contracture at the knee, the 90-degree flexion contracture. A well-padded short leg splint.
So your concern for non-operative treatment here was what specifically, that she was a high risk for anesthesia?
Yeah, so she's a high risk for anesthesia. She's non-ambulatory and non-verbal. So I think that combined with the fact, yeah, yes.
I mean, if should have a discussion, because would it be hard to, I mean, managing a cast versus splint is you have to see her almost every week,
Right.
make sure that it's still okay. There's just more care on your part, not that it's wrong. Whereas if you put a nail, sometimes they'll disappear for 2 months and it'll be fine.
It's true.
You
That's
don't
true.
have to worry
Yeah,
about it. So it's a kind of, you have to weigh those options.
it's true. Thank you. Question from the crowd was if I could get a nail, if you could probably get a nail with a 90-degree flexion contraction. I know probably not. So maybe if you go in for patellar, but you could probably also plate it. So and then of course there's
What are
skin
your
issues.
what are your entry point options?
Sure. So you see, you're thinking super patellar.
So, and leg position, because you said she's 90 degrees contracted.
Yeah.
Right.
So,
You have your infra patellar and super patellar, but that's where you're starting kind of you're making your incision. You can start at the infra patellar, but go lateral. So essentially lateral lateral parapatellar or even medial parapatellar. You can make different incisions that'll give you access to that. So this having a 90 contraction doesn't mean you can't nail it.
it's true. That's true. I agree. Thank you.
But what are you gonna do in the office? Like, what's your plan when, because Dr. Bushland said he has here every week, are you gonna put her in a cast?
Yeah. So she's in a splint now, and so we'd probably do weekly cast changes, skin checks, make sure that they're okay. Radiographs, of course, yeah, check how she's healing.
That something could be managed with a functional brace?
Well, she's not functional, so she doesn't ambulate and she can't move. She doesn't really contract. So technically, no.
It'd be easier than putting a cast on and off every week,
That's true.
if it holds it.
That's true.
Morning. First patient's a 31-year-old male presenting after a syncopal fall. This left non-displaced coracoid fracture. This was picked up on a CT angiogram to rule out PE for this patient. Patient was neurovascularly intact and given a sling for comfort. Next patient's a 78-year-old female presenting after a ground level fall approximately 4 days before presentation. This left distal radius fracture, neurovascularly intact, close reduced, placed into a sugar tongue splint. Next patient's a 53-year-old female, status post ground level fall, the left LC1 pelvis fracture. She was made protected weight bearing with a walker and placed on DVT prophylaxis.
What else did you discuss with this 53-year-old female with the LC1 pelvis from a ground level fall?
Yeah, so I mean, she definitely needs a fragility workup. She does have multiple comorbidities, and she was admitted for some mass, some like abscess that was in her lung that they were treating with IV antibiotics. So she definitely has a lot of comorbidities that need to be managed. Not a very healthy person.
Mm-hmm.
Next patient's a 61-year-old female that presented with this right hip intertrochanteric fracture. Of note, it's kind of unclear when this happened, probably at least a week or so prior to presentation. She is non-ambulatory after CVA approximately 2 years ago, has multiple comorbidities and barely verbal at baseline. So the decision was made to treat this non-operatively. I also forgot to mention that she does have severe contractures at both the hip and knees bilaterally. So she'll be on DVT prophylaxis.
How much pain was she in?
So surprisingly, she wasn't in too much pain. She was pretty comfortable just laying there in bed, even though she was contracted. Attempting to examine her resulted in some moderate pain, but it wasn't too severe. So it makes me think this was less acute than we may have thought. Thank you.
Morning. First case is a 71-year-old female, status post fall with a left distal radius fracture. She was neurovascularly intact and taken for a left distal radius ORIF. This is a 54-year-old female, status post fall with a left distal radius fracture. She initially presented to an outside hospital where she was splinted and then presented to the office several days later. She was neurovascularly intact at this time and was taken for a distal radius ORIF.
Jeremy,
So-
just a question on this one. This is because this is a pretty straightforward extra articular fracture. How
Sure.
far out did she present to the office? And was there any consideration of a closed reduction and splinting followed by casting?
Yeah, very reasonable. I believe she presented 3 or 4 days after the injury. You know, obviously if she presented to our ED, we would have attempted a closed reduction under a hematomal block. But I believe whoever saw her in the office felt that it was just maybe slightly too long after the injury to attempt a closed reduction in the office. And a 54-year-old lady, healthy and active, was just taken for the ORIF. This is a 74-year-old female, status post fall on ice with a right distal radius fracture. She was neurovascularly intact. Similar story, was splinted in an outside hospital. She presented to the office a week later and then was also taken for a ORIF. This is a 61-year-old female, status post fall 6 weeks prior. It was initially treated with a closed reduction and casting. I don't have the initial injury films, but this was her several weeks after her injury. And then this is her 6 weeks after her injury with residual dorsal angulation. So it was felt at this time to take her for a distal radius corrective osteotomy and ORIF.
You know, that brings up an excellent point as to what to do in this case, because there are a lot of people that heal in that amount of angulatory deformity that are fine. And you don't know that at 6 weeks how they're going to do. I mean, obviously it's going to look a little bit weird. You know, some people say it's easier to work through a nascent malunion to fix that. But I mean, that is always a dilemma to me. Do you put them in therapy and see where they are in 3 months and see if they can accept it? Or do you jump in and do it? And do you know anything more on this case as to what the actual determination to do the surgery was besides just the way the x-ray looked?
No, yeah, I mean, those were exactly the thoughts when discussing this case. You know, she had significant dorsal angulation. Again, she's a healthy, active lady. This is her dominant hand. She was in a little pain still at 6 weeks. And I think that may have pushed us over the edge to just go ahead and fix it at that point.
Jeremy, any indication on why this displaced after closed management?
You know, looking at the reduction films, I guess you see like it didn't really get the fuller hook, which may have contributed to some of the kind of falling off and residual dorsal angulation. Without seeing the exact injury films, it's hard to say otherwise, but I think that may have been, you know, that with the dorsal comminution there probably both contributed.
Yeah, I mean, you're looking at the AP and the lateral, you see there's a bone void dorsally.
Yeah.
So there's recent literature talking about risk factors for displacement in non-displaced fractures and you know, age greater than 60 and dorsal comminution or with independent risk factors for displacement. So
Yeah.
And last question on this one, did you fill that with some bone graft? And if so, what did you choose?
We did not. There is some literature, some good studies, including one in the Journal of Wrist Surgery in 2015 that showed that these healed without bone grafting. The article that I saw, in addition to several others, showed 132 osteotomies and ORFs for distal radius malunions that all healed without bone grafting. So we felt comfortable, even with the void there, to just go ahead without the graft.
Yeah, I think that's okay. I think you just know it's going to take a little bit longer. And the key with those studies is you have to make sure you have volar cortical contact.
Right.
Certain fractures where you have to open them up and you don't have that, then necessitates the need for graft.
Yep, agreed. This is an 18-year-old male status post hockey check with a right proximal pole scaphoid fracture. He was neurovascularly intact and taken to the OR for a scaphoid ORIF via a mini open dorsal approach. This is a 72-year-old male status post fall with a right proximal humerus fracture. He was neurovascularly intact, including the axillary nerve. Initial attempts at non-operative management were made. However, at 2.5 weeks in the office, he had persistent displacement and angulation of his fracture, and he was taken for a proximal humerus ORIF.
Any
So
critique
in
on the
retrospect,
position?
what could, yeah, I was going to say, what else could you do differently there operatively?
Yeah, I mean, there's a number of options with a displaced surgical neck fracture. You could attempt close reduction, percutaneous pinning. In this case, when we got him off to sleep, we were unable to reduce it closed, so that wouldn't have been an option. You could nail it, certainly would be an option as well. But we felt comfortable, or we really wanted to open it up once we couldn't get it reduced and put a plate on it.
So you have a surgical neck, right? When it collapsed into varus, you put it out where it's supposed to be. So now there's that medial gap you have there.
Yeah.
So what's gonna happen now?
Could potentially fall again.
Back into varus? So how
Correct.
do you prevent that with your implant?
Usually you put like a Calcar screw immediately if there's
And
some
where-
like posterior-
And where do you put all your screws?
and a subchondral bone.
Yeah, as far as you can go. Now, I see a cancellous screw there and proximally. Is that because the bone quality was so poor?
Correct. We initially put a cortical screw in, and then when we were manipulating the arm, it kind of all fell apart. So we replaced it with a cancellous screw and also some locking screws in the shaft.
So do you think the quality of bone in the head is better than the shaft?
No.
I would be very, very cautious of this because it just wants to fall right back to where it came from. And potentially the screws cutting through the head or the whole plate pulling off.
So Serge, do you wait then a little bit longer with this construct to do rehab? Would you start at 4 weeks instead of 1 or 2?
I would then wait longer, let it heal more. It'll get stiff, but they all get to some degree stiff. Or just use all those screw holes.
What approach did you guys use?
We did a deltoid splitting lateral approach.
I don't know, this looks a tough one to me. I would be concerned that you didn't get it all the way out of varus and the plate is not aligned correctly on the head. And what about the screws that would go into the Calcar? Did you just not get a bite there or choose not to use them?
Can you repeat that? Which screws?
The Calcar screws, the ones that
Oh,
are
yeah.
just inferior to those, did they not have a bite or did you just choose
Yeah.
not to use them?
They didn't, the one didn't have a bite and there's a lot of comminution right where they enter. And we just didn't feel like it was adding much.
Jeremy, you
Calcar
mentioned those
screws-
other. Go ahead, Serge.
I was gonna say the Calcar screws are not gonna have a bite. They lock into the plate. It's just the question where you put them.
Gotcha.
And it doesn't matter if there's comminution laterally, right? The plate is your lateral portion. They're not used like cortical screws. So you could go through comminution and through fracture, but those Calcar screws just go up against the subchondral bone of the inferior head.
Yeah, understood.
I think it's hard to predict ahead of time, but if you had a fibrillar strut, it'd be a great case to put a fibrillar strut in there first.
Yeah, that makes sense.
Jeremy, you mentioned those other alternative treatments, percutaneous pinning, which you couldn't get it reduced, and then also intramedullary nailing. Now that you know what you know about the bone quality, how would those other alternatives fare in that setting?
Probably not great. Knowing all that we know now, this is the best option we had with potentially, kind of the adjustments we talked about.
Yeah, and that's the thing to think about is that this is probably your best chance at decent fixation or somewhat terrible fixation.
Yeah, fair. Next case is a 90-year-old female, status post-fall with a left olecranon fracture. She's a low demand elderly patient with multiple comorbidities. She was neurovascularly intact, with significant bruising about her elbow. She did have some superficial skin tearing, but it was not an open fracture. So she was initially placed into a posterior splint for non-operative management. We changed her into a Zemski just so we could do wound checks while she was in the hospital. And her skin was healing appropriately before she left.
Jeremy, just one more comment on that proximal humerus. You know, when that locking plate first came out, the demonstration they had, they would put the plate against an apple and fill all the screws, and you couldn't get the apple off the plate. So all those screws are divergent, convergent, and you get fixation with the screws even in crappy bone just by filling the entire head.
Yeah.
So, and that's easy. You're there, just put them all in.
Makes sense.
Even with that though, Jeremy, I mean, what's the cutout rate typically been reported for these locking
I've seen-
proximal humerus plates?
I've seen like 15%.
Yeah, as high as 20%.
Yeah. As an 81-year-old female, status post-fall with this right proximal humerus fracture. She was neurovascularly intact, including the axillary nerve, and was made non-weight bearing in a cuff and collar sling.
Do you know of any recent humeral shaft studies showing which fractures have the highest non-union and complication rates?
Proximal third.
Yeah, and this one's, I know she's 81, probably low demand. It's just, that looks like it's gonna go on to a non-union potentially.
Yeah, it's certainly one to watch closely.
Morning. First patient is a 51-year-old gentleman who fell on the ice this weekend and sustained this right humeral shaft fracture. He was neurovascularly intact. He was closed reduced and placed into a coaptation cuff and collar. Next patient is a 53-year-old female who slipped and fell down some icy stairs outside her home and sustained this left distal radius fracture. She was closed reduced and placed into a sugar tongue splint. Next patient is a newborn male who had shoulder dystocia and difficulty evacuating from the mother and sustained this left humeral shaft fracture. Birth, yes. He was grossly neurovascularly attacked, and his sleeve was pinned across his chest.
Anna, were the lifeboats not functioning? Is that why they couldn't evacuate? Hey, so obviously in the order, put these fractures in order of commonality with a birth trauma: clavicle fracture, humeral shaft fracture, supracondylar fracture.
Clavicle, humerus, supracondylar is pretty rare with birth.
Yeah, but it can happen, and you have to look for physeal separation. So if it looks like an elbow dislocation on an X-ray, it's a physeal separation. Good.
This next patient is an unfortunate kid who was running down the stairs, slipped and fell, and then fell over the edge and sustained bilateral distal radius fractures, left worse than right. He was neurovascularly intact, sedated, and closed reduced and placed into the right side was a AP slab so that he could do self-hygiene, and then left was placed into a sugar tongue splint. Thank you.
Morning. First patient's a 7-year-old male who fell and sustained a right supracondylar humerus fracture, type 2. It's neurovascularly intact and taken for right elbow CRPP. This is a 12-year-old
What would
male.
happen if you left that one alone and treated it non-operatively?
Well, some people certainly do, and there have been studies showing similar outcomes. I know that some people will even try a closed reduction prior to casting.
Well, what would happen if you just left it like that and just let it heal? What would they look like in 3 months or 6 months?
Well, I think it would heal fine, and I mean the anterior humeral line still, intersects the capitellum, so I think that you might have a very small loss in flexion, but I think you'd still have a pretty normal range of motion.
Yeah. I mean, it's important to remember these all heal fine, right? So it's all just about talking to the parents and kind of reading the parents and seeing. So you're effectively changing their arc of motion, I guess you could argue, right? So they're losing some flexion, right? And they're gaining some extension into hyper extension. And sometimes that's not what you want. Say if you have somebody who's really into upper extremity weight bearing and doing a lot of gymnastics, and now they hyperextend 10 degrees when they do their sport. And then, there is some arguable, debatable literature out there, right, that we went through for our journal club last time do some of these actually remodel a little bit. The old dogma was that there's no really remodeling of extension, but there is some data out there that would argue that perhaps there is some some remodeling. So I think it's just what your desired outcome and range of motion is. I think that, there's always going to be a complication from surgery, but the risks are pretty low for a closed reduction and percutaneous pinning for this. So, but it's important to remember those points.
There's a 12-year-old male who fell at a trampoline center and has a left tibia and fibula shaft fractures. He was neurovascular intact as a closed injury. He was placed into a long leg cast and wedged to adjust the alignment. There's a 20-year-old male who was checked into the boards in a hockey game and had a acute on chronic left middle third clavicle fracture. He had a prior fracture treated non-operatively 8 years ago. His skin was intact. There was no tenting, and he was neurovascularly intact. He's mid-season right now. He's going to follow up and have a discussion about whether or not to treat this operatively. But we were leaning towards fixing it.
When you say acute on chronic, 8 years old, was there x-rays that show it wasn't healed?
No, it was healed. Sorry, acute on healed.
The healed in that with the tenting and
He did have a bump there, but not as significant as from this injury. And he said he did fine it the first time.
why are you leaning towards surgery the second time?
So we were leaning towards surgery for this one because of the comminution and Z deformity and shortening. And I don't know if someone's mid-season hockey, do you let them go back and play and then fix it later, or
You think he could play?
He's not playing with that.
all right.
That hurts. When you get checked into the boards, it's gonna-
I've never been checked into the boards before, so. Yeah. This is a 75-year-old female who was in a motor vehicle accident, sustained this left humeral shaft fracture. Was initially placed into a coaptation splint. We sent her out. We were planning to fix that. I don't know if anyone else presented this one. I was gone last week, but I think that this will not be easy to treat in a functional brace. Her radial nerve is intact. There's a 31-year-old male who punched a cop and had a right small finger metacarpal base fracture. He's placed into AP slabs. This is a 50-year-old female who was pulling her family dog off of her daughter's arm and was bit, sustaining a left ring finger DIP fracture dislocation, partial amputation, and a small finger open tuft fracture. The tuft was washed out and nail bed was repaired. For the ring finger, the only thing still attaching her finger to the fingertip was her FDP tendon. And after a thorough discussion, the decision was made to complete the amputation, IND, antibiotics, and plan for wound coverage at a later date. This is a 64-year-old male who was found down, extremely hyperglycemic at his group home, and sustained this C6 and 7 bridging osteophyte fracture. He was narrow intact and did not seem to have any involvement beyond that osteophyte. It's treated non-operatively in a hard C-collar. This is an 85-year-old female status post fall with a right basicervical femoral neck fracture. Was medically optimized and taken for a right hip intramedullary nail. Is a 57-year-old male who was in a motor vehicle accident and sustained a right tibial plateau fracture and a right posterior glenoid rim fracture. He does not think that his shoulder was dislocated in the accident, but it seems like it is certainly possible. He was neurovascularly intact in both extremities. He was taken for a right tibial plateau ORIF and bone grafting. And we're planning to treat the shoulder non-operatively with a sling and then therapy.
You don't happen to have contralateral films there?
Of the-
That
of
looks
the
a
knee.
little wide.
looks-
That might be
yeah.
him.
It definitely looks wide. We don't have contralateral films, but I think that I don't think that this is what his knee normally looks like. And this was, it was extremely comminuted at the articular surface. And I think he's headed towards a total knee in the not too distant future.
How was his lateral meniscus?
We had to repair the lateral meniscus.
So when you were done, did it look good?
The meniscus,
Yeah.
it looked okay. It was not a complex tear. It's vertical.
You might be surprised how well he does.
I hope so.
You say he's headed towards a total knee. I would argue maybe not.
I hope so.
Probably not for a long time. It's not gonna collapse real bad real quick.
First patient is a 53-year-old female who tripped on some stairs and fell, twisting her left ankle. She has this bimal-equivalent ankle fracture. You can see the tailor shifting on the mortise view, but a stress view was obtained, which confirmed this. She was splinted and she'll follow up in office for further management. Next is a 15-year-old male that was playing basketball when he fell on his left wrist. He has this distal radius fracture. He was closed reduced, put in a sugar tongue splint. Next is a 10-year-old female who twisted her right ankle at recess, was sent in with this right triplane ankle fracture. She was put in a long leg bivelt cast and a CAT scan was obtained. Showed pretty significant displacement of that anterior piece. A discussion was had with the parents, and they decided to follow up in the office for further planning.
They decided to go to CHOP. So they were supposed to come back and see me, didn't show, and then we were trying to get them on the schedule, and they decided they wanted to go somewhere else.
Good morning. First patient, 61-year-old male, working to clean the snow over the weekend. Who fell steps and had this displaced left neck fracture. Of note, he does smoke half pack per day, and 3 years ago had a fall, had non-displaced right neck fracture with cane screws. He was taken for a left toe hip arthroplasty. He'll be undergo a fragility fracture workup given his two neck fractures.
Got one the first time, Dan?
I didn't look to see if he did. I don't think so.
Interesting, because his femoral cortices look pretty good, but 61 years old and both femoral necks are broken already. It's something weird.
Next patient is a right-hand dominant 61-year-old female who had a crush injury, suffered a tuft and a comminuted P1 fracture of her index finger. She treated with an external fixator of her index finger. Next patient is a right-hand dominant 43-year-old man who suffered a saw injury, has open thumb P1 fracture. He was initially irrigated, loosely closed, and given antibiotics. He had a laceration to his EPL. He was taken back for pinning of his P1 fracture. At the time of the operation, we found that fracture had completed itself, and then we repaired the EPL directly. Next patient's a right-hand dominant 17-year-old female.
Dan.
Yep.
So was there any consideration of pinning it, or I mean, plating it since it was open already and you're looking at everything?
Yeah, we thought both options, but just elected to pin it. But we thought about plating and then I'll even potentially bone grafting it. But we were able to get a good reduction, cleaned up the bone edges, and just pinned it, and it felt stable.
And you got a primary repair of the tendon?
We did, yep. Our next patient is a right-hand dominant 17-year-old girl who fell while snowboarding, had third and fourth metacarpal shaft fractures. There was some, on a clinical exam, there wasn't a concern for a rotational abnormality, and the length appeared to be appropriate. However, the concern is that these would shorten with time. So the patient was taken for an open reduction and pitting with K-wires. Next patient's a right-hand dominant 33-year-old
Another
male.
option for fixation there. If you're going to do an open reduction.
Yeah, so you could use screws in a plate. It's just the surgeon's preference, use K-wires instead of those other options for fixing this fracture. Next patient's right-hand dominant 33-year-old male, status was fall, presented with a right index finger dislocation, metacarpal MCP dislocation, a non-displaced distal radius fracture, and a radial shaft fracture. There was a volar wound in the location of the hand where the index metacarpal fracture, an index metacarpal dislocation was. This is his radius. He was taken for an open reduction of his index finger MCP, and then ORAF of his radius.
Dan, which way did you approach the MCP dislocation?
We did a volar intraop. We found that the volar plate, in combination with the flexor tendon and the superficial transverse intermetacarpal ligament, is kind of blocking our reduction.
Do you think you could have got a lag screw across that?
Could someone say that again?
You think you could have got a lag screw through that just to compress a little bit more? Or?
I think it was kind of a short oblique. Might have been possible, but we compressed to the plate, and we were kind of satisfied with that compression. But I think the angle would have been tough.
Yeah, I think it'd be fine.
Dan, why did we go volar for the index finger?
He had it's a dorsal, dislocation. So usually the volar plate is going to be the structure that could be blocking it, so they get access there.
So typically it's a lot easier just to go dorsal, even with the dorsal dislocation, but we went volar because it was already open there.
Yeah.
Dan, what structure do you have to worry about when you do your volar approach to the MCP joint, especially the index digit?
Do you have to worry about your, condylar nerves, your nervovascular bundles?
Which nerve specifically?
I'm not sure.
So it's going to be the radial side of that digital nerve. It's going to cross right over the level of the metacarpal head. And I've almost gotten burned before. It's right underneath the skin. So you got to be looking for it right away.
How do you assess for stability afterwards? Because these joints aren't really inherently stable. In any thought to pinning it, or was it just not necessary?
I think we took it through a range of motion afterwards, and it seemed not want to sublux. After we started initially by open reducing, and then proceeded to do the radius, and then we reassessed at the end of the case. It was still stable. Next patient is a 29-year-old male. He was in an MVC and had this right distal radius fracture. As you can see, he had like associated dislocation of his carpus involving the styloid and a dorsal portion of the distal radius there. He underwent a closed reduction and a CAT scan was obtained. Which we know the axial cuts. He was nervovascularly intact. He was taken for a distal radius ORIF with fragment specific fixation.
It's a good job. That was a nasty little injury.
Yes, this is the TriMed system, and it worked really nice.
I mean, that's exactly how I would have done it. That's extremely complicated. My only question is that radial plate high enough? Because your radial fragment is very, very small. Are you sure you captured it with your plate there?
I think we definitely captured it.
The plate's certainly sitting where it needs to sit. You can't get any more distal with that.
I think that's an awesome job.
I agree.
Yeah, you see on that second view how the fragment almost looks like it's slightly older relative to that plate. I
think they still got it.
Nice.
Next patient is a right hand dominant 39-year-old male. SAS was fall, presented with his right distal humerus fracture, articular bicondylar. He was nervovascularly intact. He was taken to the operating room for open reduction and joint fixation. Next patient's a right hand dominant 58-year-old female. SAS was fall, the left distal humerus fracture. 30 years ago, she had a MVC and had a comminuted distal humerus fracture that was treated in traction and with external fixation. And she developed this malunion of her distal humerus. Additionally, at that time, she had a radial nerve palsy that required tendon transfers. She'd been functional for 30 years despite limited mobility and function in this upper extremity. However, she fell and had this non-displaced this transverse distal humerus fracture. Initially, it was attempted to be treated conservatively. However, she ended up displacing, having symptomatic crepitus. She was taken to the operating room for an open reduction and joint fixation, where we just fixed her back to her previous deformity. So next patient's a right hand dominant 59-year-old female. Status was MBC, presented with a left open humerus fracture, in addition to a left open elbow dislocation. She has significant soft tissue injuries anteriorly over the shoulder, and then medial and lateral around her elbow. She was provisionally splinted, and her radial nerve was out. She had antibiotics and took her to the OR initially for irrigation debridement of her wounds and ORIF of her humerus by posterior approach. We visualized the radial nerve and it was intact without any apparent injury. She was splinted and she's undergoing further evaluation for her elbow in addition to plastics coverage for her wound. So she had arthrotomy at the time of injury, and then intraoperatively noticed that she had instability at the elbow when manipulating it. She definitely has her LCL on the lateral side is torn. We got a CAT scan of her elbow to see if there's any bony injury there, and there wasn't. She's going back to the OR today for examination and anesthesia, LCL repair.
Well, there was a little fleck off the coronoid. You couldn't examine the elbow until it was fixed. So the humerus was fixed. Once the humerus was fixed, it was clear that the elbow was unstable.
Will your did you preemptively leave a little room for like an internal joint stabilizer in there?
Using like internal joint stabilizer is like an option.
But if you use that plate and you put the screws across the entire capitellum, you wouldn't have been able to put that joint stabilizer. That's just a coincidence.
No, it's just a coincidence. We talked about it, but we're probably just going to use a suture anchor and left room for the suture anchor. There's plenty of fixation distal, so I don't usually go too long with those screws anyways, just so I don't want to mess with ever being close to the joint.
Did you consider like fixing it at that time?
Well, we knew we were going back, and that was sort of at the end of the case. We knew we were going back to wash her out again, and so I decided just to wait.
I got you.
Carlos, if you are going to do a suture anchor, you may want to consider a internal brace on top of it as well, just in case there's a lot of manipulation with that. Yeah, perfect.
Yeah. Next patient's been previously presented. It's a right-hand dominant 59-year-old female who fell, had a complex shoulder dislocation. She initially was reduced and was discharged. However, she subsequently returned due to volume pain and loss of function in her right upper extremity. She had a stroke workup and full evaluation, which she presented, and was concerned that she had some sort of plexopathy. She returned to the office about 2 weeks later, got repeat x-rays, and her brachial rosette completely displaced. She was taken to the operating room for an open reduction internal fixation of the tuberosity piece.
How did you approach that one?
We did a deltoid split, and then we were able to find that piece and pull it back. Luckily, it wasn't very retracted, and we were able to get a good reduction. The Italian preference was use these Kinsella screws with washers, and they had great bite. And then we did like a stitch to the cuff, and then tied it down to that cortical screw you see distally the neck. One option is you can also use a plate as well, tied into the plate. But her bone was pretty good. Next patient's a right-hand dominant 77 female who fell, had this displaced proximal humerus fracture. She was neurovascularly intact. She initially was taken for a closed reduction percutaneous pinning, and this went well. However, 2 weeks, she had pin migration and displacement of her fracture. She was taken, had those pins removed, and had a trial period of non-operative treatment. However, she continued to have pain, instability, and loss of function of the arm. So she was obtained a CAT scan to further delineate where her fracture was for operative planning. For her, that retained broken pin was.
What was the CAT scan for the fracture or for arthroplasty preparation?
Arthroplasty preparation. So the plan was to do a reverse total shoulder.
And were those just to go back to the pins real quick, were those fully threaded pins or terminally threaded pins or smooth pins you used? And were they bent outside the skin?
They're fully threaded pins. And I think you cut them right below the skin.
The CT scan, what about the CT scan helped you with the arthroplasty reverse?
It's gained the idea about the glenoid and planning,
Is that typical pre-op for a reverse for a after fracture? Is there something wrong with the glenoid from the dislocation you're worried about?
It's for templating the glenoid, so you know the version going into the case, also the glenoid bone stock. You're right. Typically, we worry more about that with prolonged arthritis, where they have abnormal glenoid wear, but it's still helpful to use this blueprint software for templating and they create patient-specific instrumentation that we use in the operating room.
When she had her original fracture, was there a CAT scan obtained then or no?
No.
No, yeah, because usually with the fracture, a lot of times you have the CAT scan is done because of the original fracture. I just didn't know if she had one to begin with.
Can you use an old CAT scan, Jamie, for the templating, or does that have to be a specific CAT scan?
It just has to be a CAT scan with URED, so it can be an old one.
All right, thank you.
First patient is 44-year-old male, status was MVC, who came with left type 3 open distal tibia fracture and left perilunar dislocation. Initially, he was taken to the OR for tibia IND X-fix placement, as well as wrist close reduction and splinting. He also had like excessive laceration over the forearm that was IND and closed. The patient came back to the OR for left tibia open reduction and internal fixation and wrist open reduction and percutaneous pin. Next patient is 72-year-old male, status post-fall, with left B2 periprosthetic femur fracture. Patient was indicated for left hip revision hemiarthroplasty. Next patient is 56-year-old female, status post-fall, with left femoral neck fracture. Patients sustained a femoral shaft fracture 20 years prior presentation, and she was fixed with the intramedullary nail. The decision was made to take the patients to the OR for left femur removal of intramedullary nail and total hip arthroplasty. Next patient is 68-year-old female, status post-fall, with left distal tibia fracture. The patient was taken to the OR for left tibia open reduction and internal fixation. Next patient is 91-year-old male, status post-fall, with right hip basis cervical neck fracture. The patient was taken to the OR for right hip intramedullary nailing. Next patient is 34-year-old female, status post pedestrian stroke, who came to the hospital with right open femoral shaft fracture. And the patient was taken to the OR for right femur IND and intramedullary nailing. Next patient is 67-year-old.
Can you go back
female.
one? That what? Sorry, what nail is that?
So that was difficult case. So we start the case with the piriformis entry reaming. We put guide wire and we start reaming the isthmus. And with the first reamer, we got difficulty to go through the isthmus with 9mm reamers. So we spent like 20 minutes reaming the isthmus with the smallest one. So finally we go up until the 10mm. So we couldn't place the piriformis entry nail because the smallest size is 10. So we decided to use adolescent nail, which unfortunately is a trochanteric entry nail or lateral entry nail. During the case, we placed this nail, we replaced them with the longer one, but with the longer one, there's like prominence and the patient was small, so we couldn't accept that. So we did make the decision to put this shortest nail and a little bit deeper, and we fixed this with a little valgus.
There is a I'm assuming you used the tan fan nail first, the piriformis.
Yeah, we were
entry?
trying, but the smallest one was 10mm wide. And
There's the Synthes has their piriformis recon nail. That's a 9mm smallest. That's in-house if you ever need it again.
Yeah, I think it's going to be fine, but we almost got the 10 reamer stuck in there. And I just did not want to ream anymore.
Yeah, it just looks a little valgus.
Next patient is 67-year-old female, status was full with left ankle trimal fracture. CAT scan was obtained. And patient was taken to the OR for left ankle open reduction and internal fixation. Next patient is 77-year-old male, status was full with right hip IT fracture. Patient was taken to the OR for right hip IM nail. Next patient is 51-year-old male, status was full with left ankle trimal fracture. Patient was taken to the OR for left ankle open reduction and internal fixation. Thank you. That's all cases for today.